Walk me through an example. United, and I participate in this program, and I raise my prices. What happens?
You raise your prices, and the enrollee doesn't feel or experience any of that
Got it.
price increment. And so they're still they'll argue that they're still competing along other margins, along service quality and different aspects of plan design, perhaps. Although a lot of that stuff is actually pretty regimented. I mean, because you have to have a metallic designation. Silver plan has to be defined in a certain actuarial way. So there's not actually a lot they can tweak. The key point here is that there's no real restraint baked into the system in terms of premium growth because they're not competing on price.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
Okay, welcome to the latest edition of the Scale Community Analyzing Healthcare podcast. I'm joined by Tony LoSasso. Am I pronouncing that correctly, Tony? Okay, so great to have you here. So the reason why I reached out to Tony is I read very recently a Wall Street Journal article called "The Real Fix for Obamacare," and I found the topic to be really interesting. And so we wanted to use this time to maybe get into some of the conclusions that you offered during this article, if that works for you, Tony.
Sure, absolutely.
And so your background is you're a professor of economics at DePaul University?
That's correct.
Okay.
And I guess I'll add to that as of January 1st, I will actually be starting at the University of Wisconsin-Madison in the La Follette School of Public Affairs.
Okay. It's good to hear that because I have a few friends who go to the University of Wisconsin, friends of my children, I should say. So I will alert them to the fact that you will be there and teaching.
Yes, very soon.
Great news. So I want to get into the real fix for Obamacare. You really focused on the question of incentives, specifically with vis-a-vis these subsidies and where we got it wrong. So why don't we start with a very basic question. Imagine we had a time machine and we went back to around 2010, I think, when the law was enacted. How would we structure the incentives differently to get very different outcomes?
Yeah, that's a great question and great place to start. So the main thing that I guess I want to convey, I suppose, is that there's a lot of debate we heard during the shutdown about the enhanced premium tax credits. Those are ending as of the end of 2025. And so now those were not part of the original Affordable Care Act that, as you mentioned, was passed in 2010. Those were added during the pandemic and extended with some of the pandemic legislation. And basically that extended, those enhanced premium tax credits extended what were the original subsidies for health insurance, the original premium tax credits as part of the Affordable Care Act. So I think there's a little bit of confusion, I would say, that people think that all of the subsidies, the premium tax credits, are ending at the end of 2025. They are not. It's the enhanced ones, the ones that basically lift the income cap on the original Affordable Care Act tax credits. So you may have heard some of the arguments are that, well, people making $200,000, $300,000, $400,000, $500,000 a year should not really be eligible for premium subsidies. So I just want to make that first of all clear when we get into kind of what the changes are. Now, what I'm suggesting in the piece, and my co-author, Coasley Simon, at Indiana University, what we're suggesting is that what you could do to maybe strengthen an aspect of the original design would be to change the subsidy so that it's not what effectively is a defined benefit. So you get the subsidy amount gets determined by your income. And so any increases in premiums that you might see, and again, to add more to the kind of confusing mishmash of ideas that we've heard in these last couple months during shutdown, is that people are expecting there to be large premium increases in the coming year, in 2026. And that's happening for a lot of reasons. And it's a real thing. It is a concern. But what our argument is that part of why that's happening is really the subsidy design itself, and really part of the reason why premium growth has been so high in the Affordable Care Act marketplaces, as they're called, is because of the subsidy design itself. And it gets back to this defined benefit nature of the way the subsidy is structured. You get an amount, you pay an amount as the enrollee, and that's going to be determined by your income. And any increases in the premium above that, you feel none of it. It doesn't matter to you because you're...
To put it in layman's terms, the difference between gross premium increases, which continue to be substantial, very rapid, and net premium, which is net to the actual end consumer, the given patient, the patient's family. That gap has been filled by the government. That is funded by tax revenues.
Correct.
And so all voters are oblivious to the fact that this cost of healthcare is going up and up and up and up and up because someone else will take care of it, namely the government.
Which are the taxpayers, of course.
And that gap went away right about now with the expiration of these subsidies. They were always supposed to expire, but were also, wink, wink, supposed to be extended indefinite.
Well, yeah, it's you've got it partly right there, because the low-income people are still going to be completely fine. I mean, they're going to experience the same subsidy regime, pay no more, despite the fact that premiums may be going up 10, 20%. Lower income people will pay no more.
Partially underwritten by the government. Spread.
Entirely underwritten by the government. Yes. Now, yes, the enhanced premium subsidies will be going away for those higher, or at least they're slated. I don't know what's going to happen, but as of right now, as the law is written, they're slated. They were slated to end at the end of 2025, and that is, that's as it's written now. And that was not written over this past summer. That is something that was, they were to be sunsetted because the pandemic is long since over. So again, a lot of the debate has kind of conflated these couple of concepts here, that there are these subsidies. Low income people actually are not going to be affected by this change. Higher income people will be, because the enhanced premium tax credits affected higher income people. They will experience a reduction in the subsidy amount. However, despite the change in premiums that are expected, the out-of-pocket premium component that they experience really is only going to be the effect of reverting back to the original ACA subsidy regime, which again is tied to your income. So what we're saying is there are reasons to think that it would be better, and I'll get into what they are, to instead provide a defined contribution amount. So a given fixed subsidy, and then anybody who wants to buy more coverage, if they want to buy more coverage, right?
Defined contribution, defined benefit. The difference between, I voluntarily choose to spend more to use more versus I can use as much as I want. I'm not worried about it because the government is underwriting this entire program. And just to put numbers on it, when the subsidies first started, we were talking about back, let's say, I'm looking this up, 2014, $18 billion on ACA subsidies from the federal government. Projected 2025, ACA subsidies, $138 billion. So almost a tenfold increase. And my guess is it's not that the volume of healthcare usage, number of treatments, procedures has gone up tenfold. Certainly the population has not gone up tenfold. And I want to be careful what I say because I haven't done the research on the spread or the growth of ACA membership during that period of time. But I'm guessing, Tony, what you're going to tell me is insurers have been increasing pricing at a very rapid pace, regardless of usage, because the government has been there to fund this every step.
Well, I'll go one further and just say that the nature of the subsidy.
It's been a very happy time to be an insurer.
Well, it's been happy times to be an insurer. That's right, in this market because there's no reason for them to offer competitive premiums, so they don't have to compete against one another on price, in effect, because 98.
I've heard all day, so I want to really drive that point.
Yes.
Walk me through an example. United and I participate in this program, and I raise my prices. What happens?
You raise your prices, and the enrollee doesn't feel or experience any of that price increment. And so they're still they'll argue that they're still competing along other margins, along service quality and different aspects of plan design, perhaps. Although a lot of that stuff is actually pretty regimented. I mean, because you have to have a metallic designation. Silver plan is has to be defined in a certain actuarial way. So there's not actually a lot they can tweak. So, but again, I think the key point here is that there's no real restraint baked into the system in terms of premium growth because they're not competing on price. In this case, the enrollees don't experience any of it. They're covered. Something on the order of 98% of enrollees are getting a subsidy. So
for spend to go up tenfold in a 15-year period of time, you're looking at, I'm just estimating, 20 to 40% annual increase in prices. And
it's probably not that much, but yeah.
It's high. It's not 10% to get to.
It's high. It is high, and certainly outstrips the inflation. Growth. Inflation and medical inflation. Yes. And the growth.
It's hospital inflation, which is almost unimaginable.
Yeah, right. No, that's right. So we think it's a structural flaw that is by design in the original design. I don't know, I can't speculate on what the sort of political economy was that went into the decision to structure it this way. I could speculate. I mean, I could be, this is a convenient way to get buy-in from the insurers for this whole system. And maybe you need to do it. Maybe you need to structure it this way. I don't know. I'm not the person to answer. I wasn't involved with, creating the legislation that created the Affordable Care Act back in, as you say, the debates of 2009. So this is a chance. Is it wholesale destruction of the Affordable Care Act? No. Is it incremental steps that might improve?
That's a piece that's missing. It's framing the narrative in the most constructive way possible. If I was leader of the Republican Party, I would say, ladies, gentlemen, let's reach out to the press and the public with the following sentence. Obamacare is awesome. ACA is fantastic. I completely understand what President Obama and Nancy and Kennedy, I think at the time, I think this was just before he passed away, sort of simultaneous. This was like the final kicker that drew the final vote that Kennedy passed away, if my memory serves me right.
It was around that time.
I understand what they were trying to do here, pushing 50 million uninsured down to 15 million uninsured is a noble pursuit. However, there were some fundamental flaws. And you know what? We've been just as guilty of committing mistakes as the other side has, because none of this is easy. Let's all get together around a table and get to work on the flaws and keep the stuff that's good. But you'll never hear either side speak that way. Instead, it will be the other side are lunatics. They invented a complete shit show. We must destroy it all and only go in the opposite direction. Whatever that is, it must be the right direction because it's not what they voted.
Well,
sounds right.
Yeah, I can't speak to the politics on the matter.
You hear what I'm saying?
I do.
Critical thinking versus political thinking.
They're going to try to score points. Both sides are going to try to score points, of course, with their base. And yes, unfortunately, often sound policy, gets left by the wayside when you start going down that road. however, would like to think that there's a reasonable trade here to be made where both sides, you want to structure these things ideally so that it's a win-win. So maybe the trade is extend premium tax credits for another year or some time, and then at the same time you're creating this new system that, again, I would characterize more as a defined contribution system. It sometimes goes by the name of managed competition. It's also, for what it's worth, it's very similar to the structure of the federal employee health benefit program, the very same people who are going to be voting on this, how they get their health insurance. They get essentially a fixed contribution, a defined contribution amount. If they want to buy a richer plan, they pay the differential above that. Insurers, importantly, have the incentive to try to keep premiums as low as possible because they know that the marginal dollar that marginal incremental or the marginal dollar that they add to premium is borne entirely by the enrollee. So they have to think very hard. Well, is it going to be worth it? Because I'm going head to head on each marginal dollar against my competitors. And so they matter. Whereas now they almost completely don't matter. And all of them know that, and they can just go ahead and increase premiums because it doesn't matter. The enrollees aren't paying it. If you switch it to a defined contribution sort of structure, now you're generating competition. This can result in real reductions in premiums, or at least a significant slowing in the upward trajectory of health insurance premiums in the marketplaces. And that will have, really solid savings effects down the line for all of us taxpayers and the enrollees themselves, and hopefully create a more robust marketplace for health insurance, which is, I think what at least, I would like to see. I guess I don't like the visions of I don't like the alternative visions that are often thrown around, single payer or just dumping everybody into Medicaid.
Or oligopolistic payers, right? Or the disinterest in large swaths of our populace that are not participating with any kind of payer like this. I want to take you back to the mindset. You're in the room, just like the Broadway play with that song, You Were in the Room. So let's imagine we were in the room and Hamilton is the play. Someone is pitching you, Tony, and Obama. You're Obama's #1 advisor on Obamacare. What is the elevator 10-second pitch on Obamacare? I think it sounds something like this. Correct me if I got it wrong. And I wasn't in the room, so I'm guessing.
Neither was I.
Fine. Hey, President Obama and Tony, we've got a problem. We've had this private insurance industry that we have participated in with wonderful managed care products for years. And no matter how much we tell them that we're concerned about this 50 million populace that is not covered, they don't seem to hear us. They're quite rigid about the PPO plans, the managed care plans, the HMO plans, and yet nothing seems to be happening with the 50 million. We're going to have to solve this problem ourselves. We're going to create a heavily government subsidized payer marketplace with features and benefits that we think make sense. And lo and behold, you'll see, I can't speak for the 10 million illegal residents that are all over the place and it's very noisy. I can't speak for the 10 million who just will refuse to buy insurance from anyone no matter what. And those people do exist. But those who just would love to buy it, but they're in this little weird spot where they're sort of employed, not employed, 1099, not getting W-2 insurance. No one's making it easy for them and they just can't afford it. We're going after that group. Let's go. Please help me build this. Was that the pitch? I mean, it's a little longer than 10 seconds, but just to sort of level set, what was the intent here?
Well, yeah, I think you're exactly right. The intent was, yes, we were at a time when there was something like 45, 50 million.
The Europeans are laughing at us. We don't care about our people. Enough already.
Yeah. So yes. So you want to. That was the aim. That was one of the key aims, and arguably, it was successful. We did reduce it.
So that was my next question. And I want you to fill out the last thought. But while you're doing that, I was leading you somewhere.
Okay.
I think Obamacare was consistent across the board, and I think whether it was intentional or unintentional, they didn't really care about the money. They wanted the movement, and I think you see that in value-based care incentive programs like ACO REACH as well, and Medicare shared savings and Medicare Advantage. Rapid adoption. Don't worry about the fact that some of the economic incentives here are completely misaligned and will be abused. We'll deal with the headlines later. We'll make corrections. Okay, we might overspend $100 billion in any given year, but we spend $2 trillion on healthcare as a collective government. What's $100 billion? I think that's sort of what they had in mind. And what they didn't budget for is that the country would be at $38 trillion of debt by 2025. That was the unanticipated, that we would be tightening our purse strings aggressively.
I think that's fair. Nobody, obviously the pandemic, came out of the blue, and then we spent like crazy. So, and a lot of the spending tends to be sticky, right? You start spending it, you can't stop spending it. But I guess to your initial point there, the argument was that, well, it's going to be a threefold thing. We're gonna amp up. There was a non-group health insurance market that existed. It was there, not widely used. So part of it was amp that up, call that the marketplaces, fundamentally restructure it, and that was bringing in community rating. As that would be the technical term for it, but that's if you have pre-existing conditions, you won't be charged a differential amount based on the existence of those pre-existing conditions. That's a whole rabbit hole there as to whether that actually is insurance when you are effectively buying homeowners insurance after your house is burned down. We can talk about that. Separate issue, really. But okay, so that's step one. Step two, expand Medicaid to that adult population, low-income people, very low-income people who are adult and aren't eligible under the traditional categories. That would be children and pregnant women, that sort of.
Right.
And then the individual mandate. Okay, so make people enter the pool,
And
whatever it is.
Right. Initially, they were going to tax those who didn't participate.
And that is correct.
The Supreme Court got involved and said this is commerce. You can't actually penalize someone for not buying something. But that was the mindset. How do we get 50 million uninsured down to zero?
Yeah. Right. So it was those three things, in brief. Obviously, there's a lot in the bill, but those were sort of the three major components. Now, as you point out, there were lots of other. I mean, it is called the Affordable Care Act, so that it kind of puts affordability first, in the name of it, of the law itself. And so, we heard a lot of statements around bending the cost curves and this and that. Obviously, that hasn't really happened, and so cost curves have not really been bent.
They have.
They've probably been bent upwards, yeah.
Not because of this.
Yeah.
And not in some very critical areas.
Fair.
So I think it's a wonderful case study in a few things. One, and I'm interested in your thoughts in all of them as a true economist. One, hey, if you want good supply in healthcare, you better be willing to experiment and go through all kinds of complexity and failure. If you want bad supply in healthcare, go single system. You'll run out of supply, but boy, it'll be awfully simple. You'll all understand it. The government pays for everything. The government employs everyone. It sucks. It's terrible, but at least we don't have to experiment with lunacy on a regular basis. So those are the choices. Either crazy schemes that partially work, mostly fail, occasionally work, and a real marketplace for ideas and experimentation. And I've said this before, I take my hat off to CMMI, the CMS Innovation Lab for Medicare and Medicaid. I take my hat off to Medicare and Medicare shared savings. I take my hat off to everyone and I've spoken to some of the senators who are involved, everyone and some of the head of Harvard Medical School that was involved, everyone who's involved in this, because this was a concerted. This is almost reminds me of the West Wing. I started watching the West Wing the other day, and everyone is so bushy-tailed and so excited to fix the world, right? It's America, goddammit. We're going to fix everything. But unfortunately, healthcare is a bigger beast than anyone can possibly imagine, and there is no silver bullet for any of it. It's all very
I'm sure you know the old joke, it's all about cost, quality, and access, but pick two.
That I never heard that before. That is brilliant.
Because you could squeeze the balloon here and here. It's gonna, So, but yeah, I mean, again, it's
So,
The
so
intention was there.
the anti-government libertarians will say, perfect example, government boondoggle, white elephant. As soon as the government gets involved in anything and champions anything, $120 billion later, it's a mess. And I would push really hard against that and say, what did the private sector do about this problem? Right? It's not like they nailed it either. So at least one group stood up and took a swing at it.
Yeah. Well, yeah. I mean, just I guess I'll just come up with the one counter to that statement is that we still do live in a world where employer-sponsored health insurance receives approximately $300 billion per year tax subsidy, tax expenditure, because we're not taxed. It's not taxed. Our employer-sponsored health insurance is not taxed. It's something we value. It's something that's part of our pay. But unlike our wages, which are taxed, our ESI is not taxed. So there's a baked-in subsidy.
Generous for not taxing us on our health insurance when they
and again, I
do and take $5 trillion of federal revenues and increase it even further. Thank you, Mr. Government.
Well, yeah, I know exactly, but it that sort of thing does create distortions. A massive, tax subsidy there.
Point. It's a fair point.
So it's it's distortions all the way down. I'm afraid that's the that's American healthcare, but also it's probably not unique to America as well. So
not at all, and I think we see private insurance and the complexity of it and the beauty of it manifest all across the world. It's a wonderful topic for me. I was interviewing the CEO of Academy Health last week, a US association that's grown up over many decades as a really good leading sort of analyzer research think tank for what's going on in US healthcare. And I agreed with everything the CEO had to say. And his thesis was really like, it doesn't come down to the insurance industry. You can focus on insurance all you like, but at the end of the day, if hospitals aren't structured correctly, you're going to deal with 10% annual inflation. And I thought that was very elegant of him to say that, but listening to you, I don't agree anymore. I think that US healthcare is very finely balanced and that all these different constituents have a huge role to play. And anytime any element loses its balance, all kinds of perversions bubble up to the surface within minutes and we're left trying to explain them and address them and fix them. So it's really everything is important in US healthcare, which makes it so fascinating.
Yeah. I mean, I just, this is again, apropos of nothing, but I was in the, 2 weeks ago, I was in the Czech Republic and I was speaking to some students there. And it was this triple degree program. So students from Czechia, Germany, France. And I was talking about American healthcare. And I said, contrary to what you might think, actually in the US, we have every type of healthcare system. It's all here. Like if you want, again, a total private, something akin to a private market, private insurance, you go to private doctors and private hospitals, all that stuff. Obviously, we've got that. We've got public payer, but still you go to private. And then we have the public sector owns all, we've got the VA, which is publicly owned throughout from
state-funded hospitals as well. Beyond the VA, state-funded hospitals are state administered.
And we have plenty of public hospitals and providers as well. So it's all here. You get your pick of everything, and so that's probably quite unique. I don't know that feature, if you call that a feature or a bug, exists anywhere else in the world. It
leaves guys like you and me with plenty of things to analyze, which I really appreciate.
Is the Health Policy Analyst Full Employment Act, to be sure.
Very well said. Tony, I really appreciate your time today. And I want to draw everyone's attention to the incredible article that you wrote in the Wall Street Journal and look forward to what you publish next.
I appreciate it. Thank you so much for inviting me. It's been a great conversation.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.